Yep. Thanks so much, Madhu, and good evening, everyone. I'm just going to share my screen. Okay, we've checked to see if it works, but if anyone can't see it, just let us know. And just to thank you in advance to Ida, who will be, he'll be the RA for this, or the teaching assistant, sorry, for this course. Okay, so like I said in my email, this is a bit of a pause on analytic epidemiology, so what we learned last week, which is really about helping us to understand associations between exposures and outcomes, as well as causation. So when we talk about outbreak response, we're more talking about descriptive epidemiology. And that's about describing the distribution over person, place, and time. So throughout this lecture, you'll hear a lot about person, place, and time, but that's really what descriptive epidemiology is. That helps us to estimate the number of people that may be affected in an outbreak or an epidemic. And I would just say, just think about disease detectives. I don't know if you've ever heard of Epidemiologic Intelligence Service, but this is a lot of the boots on the ground work that is done at the beginning of an outbreak, especially, but also throughout. So when we think about outbreak investigation, we think about disease detectives. So here are the session objectives. We're going to spend most of the time on objective 3, which is describing the steps of an outbreak investigation, like I previewed last week. It's about 10 steps. But we'll start by talking about the pillars. Hey everyone, can you please put your phone on mute or your computer on mute, please? Okay, thank you. So we'll start with talking about just the pillars of an outbreak response and who are the key stakeholders. I've tried to, based on feedback, it's just really sprinkle in areas that as journalists you all can reflect about and think about what is the practical application of some of the things that I'm talking about. It would be great to know if this is useful for you. Okay, so first is why do we even why do we investigate outbreaks? I mean, the primary reason is really that during an outbreak, we want to identify what the source of the outbreak is, right? And we want to be able to institute public health measures to prevent future transmission or future episodes of the disease and really just reduce transmission altogether. So that's the primary objective, but these other points are very important as well, because while you're doing an outbreak investigation, you are responding to public's concerns. A lot of the studies that Professor Madhu has been talking about and I've been talking about, this is based on a lot of the data and the information that we get from outbreak investigation. It also allows you to test control strategies. So just through all of our experiences with COVID-19, a lot of what we've been doing, even though they're tried and tested epidemiologic strategies, in different contexts, you get different results. So lockdown in one place looks very different from lockdown in another place. You know, wearing masks, you know, and having evidence to wear a mask or not wear a mask, that's really come a long way within this outbreak, or I mean, within this pandemic. So doing outbreak investigation allows us to test those strategies. It also constructs a link that's between clinicians and public health specialists, and that link hopefully will continue beyond the outbreak, because that's really where we have strong health systems, when there's a connection between clinical and public health. It also helps us to address political and legal issues, especially when we're talking about global health law. Many of you may have questions about WHO and public health emergencies of international concern. So when COVID-19 was officially declared a pandemic, or when it was seen to be what we call a FEAC, this public health emergency of international concern, that's going into more global health law, but it also helps us to address local laws and local legislation. So, you know, is it lawful to do a lockdown? Is it lawful to keep people at home or to make people go to work during an outbreak? So these are different reasons why we investigate outbreaks, but it's also a training opportunity for not just up and coming epidemiologists or clinicians or infection prevention specialists, but also experienced seasoned people as well, because again, different contexts come with different challenges and opportunities. Okay, so the first step, once an outbreak is confirmed, is to really assemble a team to ensure that all the activities for the outbreak investigation and response are able to be established. So these are kind of the traditional pillars of outbreak response. And I'll just go through them really quickly. So we have surveillance and epi. So it's a lot of what we're going to talk about today and what we've talked about last week. This really is about just understanding transmission dynamics. Case management. This pillar is about treating and supporting the unwell. It's also very key to reducing transmission by isolating the infected people. Then we have laboratory, and this is critical to case confirmation. So I'm sure we've all heard about, confirmed cases versus suspected cases, but laboratory is critical to really being sure that certain people have the infection, and that we understand, where the transmission is going, and we're doing what we can to get in front of it or to stop it at least. Then social mobilization and community engagement. So I think not just through COVID-19, but even with the Ebola outbreak or epidemic, you would see that communities are essential. They have to buy in order for public health measures to succeed. And we need public health measures to reduce transmission. So if you think about all of the kind of public health messaging around washing your hands and social distancing, this is all contingent on the buy-in from the community. So we have professionals that help us to get that buy-in. And then finally, we have coordination, security, and logistics. And this is just really essential to ensuring that multiple stakeholders really are able to play their part and to do the roles that they're assigned to do. And in some settings, you'll need security experts from maybe conflict areas, or, even in places that just don't want to wear a mask, or there's other political unrest or demonstrations going on. Okay, so when we think about who responds to outbreaks, a lot of this is captured within those pillars, but this slide is really to show you that there's kind of two layers. There's an organizational layer. So these are collaborators, maybe government officials that have a mandate to respond to a public health emergency or a public health crisis. But you could even include in that organization the affected population, because as I just said, they have to buy in. And I mean, everything is about what's happening locally. Then you could have non-governmental organizations, and you often do have governmental organizations, as well as community-based organizations, even civil societies, which like CSOs, civil society organizations. That's not on here, but they're also quite important when it comes to outbreak response. On the right side, you see more of the technical functions that have to be delivered through professionals. And so there's different types of professionals that coordinate logistics and coordination, as well as epidemiology. There are infection prevention and control and case management professionals, specifically at the hospitals or health facilities. And then we have water sanitation and hygiene professionals who are really critical to ensuring that there are appropriate sanitation, so like hand washing stations, but also that certain hazardous waste are disposed of in a responsible and safe manner. And then, as I said earlier, we have the social mobilization, but also psychosocial support. So with a lot of outbreaks, we have situations or issues around stigma and fear. And so it's really important to have, psychologists, clinical psychiatrists, therapists, or just people that are trained with these skills to really support those that are affected. So this is just kind of a snapshot of the type of organizations that you may see, especially when we're talking about large outbreaks, international outbreaks, outbreaks that require international coordination. And we see that a lot in Africa when it comes to kind of multiple country epidemics, as well as outbreaks and epidemics that are in either conflict areas or humanitarian areas, or just areas that require a different level of specialization and coordination to respond effectively. So on here, you'll see that there's some ministries of health. So I used, for example, the Nigeria Centers for Disease Control, which is not the Ministry of Health, it's the National Public Health Institute. Yeah, the Ministry of Health here is the Republic of Uganda Ministry of Health. So those government institutions usually are the lead institutions of any outbreak response in a country. You'll see there's humanitarian actors like MSF and IRC. And in recent years, I just add that, you know, there are other organizations on here, such as WHO and CDC, and WHO is always very important in outbreak response, not just, you know, the WHO that sits in Geneva, but the WHO at the regional level. Like here, you'll see this is Southeast Asia. There's also WHO African region, and there's 6 regional offices across the world for WHO. And historically, very strong public health institutes like the United States Centers for Disease Control and Prevention have been really critical in responding to outbreaks, especially in different African countries, and providing that technical support. But in recent years, we've really seen an increase of African institutions supporting each other internationally. The emergence of Africa CDC in 2000, and I believe they started in 2017, that has been really helpful. We would see during COVID-19 that they were essential to ensuring that laboratories across the continent had the capacity to diagnose COVID-19. And right now they're doing a lot of work to kind of streamline vaccine access when that's available, treatment access when that's available, as well as PPE. So we have a lot of, on the continent, there are much more continental resources to support outbreak response instead of relying too heavily on the West and the global North as we have in the past. And I for one really hope that that increases and that we continue to see higher capacity on the African continent. All right, so when we're talking about outbreak response, it really requires a lot of human and material resources. And success means that you are well prepared. So these are some of the questions that we have to ask ourselves before we start, you know, really implementing or executing an outbreak response. And outbreak missions can be really lengthy. So it's not just looking at experts in communication and transport for, you know, the first 3 months. I mean, COVID-19 was officially declared an emergency by WHO in January 31st. So we're already 5.5 months in. But then if you look at the recent Ebola outbreak in DRC, that took 22 months before it was declared over. So you can be in for the long run. So it's not just finding those initial resources at the beginning. It's also making sure that there is a stream, that there is kind of a surge capacity available throughout the outbreak as well. Okay, so this is one of the in practice slides that I was talking about. So now you've seen that there are several stakeholders that are involved in outbreak response. And so I think it's really important to understand, you know, outbreaks and epidemics from very different angles, because of course there's a professional component. We need to know the information. We need to have scientifically robust and sound data to guide policies, to guide individual actions, but also, are we capturing community voices? Are the experiences of those who have had the disease or who are afraid of the disease, are those being captured? How about people on the front lines? And yes, clinicians are important, but there are other people on the front lines as well. There are community health workers. There are people who specialize in infection prevention control. And so I just want to kind of pique your interest in exploring this a little bit deeper about what voices you're capturing when you are covering stories about outbreaks and epidemics. Okay, so this is going to be our new map. So we had a map last Thursday, and we have a map for today, and it's this list of the 10 steps of outbreak investigation. And we're going to start with the first 3. I'll just read them. Confirm diagnosis, confirm that an epidemic exists, and define a case and count them. So confirm diagnosis. So how does an outbreak even get picked up? That's the question that we're really trying to ask. And sometimes it's a result of proactive searches. So here you'll see that, there's special interests, there may be kind of based on different scientific exploration, there could be a hypothesis or that, something may exist that we may not have had the technology to detect before. So that's really when you're looking at like new techniques and special interests. It could be a lab error. You can just pick something up accidentally. There are multiple sources of information that can really indicate to us that an outbreak is happening or occurring. But what I found in just my work is that most of the outbreaks that we know of are due to clinicians and other frontline folks who give that signal. And I've always found that the best value for money, and as far as having good preparedness for outbreak response or epidemic response, is to ensure that clinicians, so nurses and doctors, community health workers, that they really understand case definitions or like the signs and symptoms of different epidemic prone diseases. So that's something that's really, really important in outbreak response and preparedness and in epidemiology in general. So most countries across Africa would have the integrated disease surveillance and response system. And so this is a reporting system on certain diseases, again, the diseases that are likely to cause epidemics. And they're reported, depending on the disease and depending on the country, they're reported on a weekly or a monthly basis. So that's how we try to have early detection of outbreaks. But also we can get notification through patients if someone comes in and they're sick and they say they've gone to an event. That really is an early indication or a sign that, okay, maybe we need to explore deeper. If they went to an event, there's probably a lot of other people who went to that event too. Let's see if we can understand the source of this illness. So that's very common for like foodborne illness. But also the local press is really critical to picking up unusual events that would prompt an outbreak investigation. I'll talk about that a little bit more on the next slide. But also community members. I have here event-based surveillance. So event-based surveillance is a way, again, to pick up signals within the community or within a country. It's not this kind of more standardized surveillance system that we call indicator-based surveillance, where the clinicians are reporting weekly or monthly. This event-based surveillance is usually open to anyone. Some countries have like a toll-free number that you can call if there's an unusual health event that's happening, or an unusual event, full stop, because non-health events can lead to impacts on health. Some countries have, integrated in their event-based surveillance some way to understand what's happening in certain social systems. So they might be able to pick up on school absenteeism. So if there are a lot of students that are missing from school, that could be a signal that, people are out sick, and that might raise the flag of doing an outbreak investigation and going deeper. It could also pick up maybe pharmaceutical prescriptions, and that could also flag, okay, why are people getting more antibiotics? What is happening in this area? Maybe we need to dig deeper. So these are different ways that outbreaks can be notified to the health officials. So of course, because I'm talking to this audience, I wanted to go a bit deeper about the importance of the local press. So in several countries that I've worked in, the local journalists in their own local languages have provided a signal for outbreak investigation in different ways. So sometimes we learn that like a group of adolescents are falling ill and complaining of, dark colored urine. And then you go deeper and we find out that there is a local outbreak of hepatitis B. The media is really important because a health system, a Ministry of Health, a National Public Health Institute can't have eyes everywhere at the same time. So the media was really essential in investigating SARS in 2003, when China wasn't being transparent about what was actually happening. There was a lot of journalistic investigations and pulling out what people were going through, what the doctors were saying, and that really helped to respond well. Once China was working better with WHO and others, it really helped to respond to the outbreak, but it also really helped the surrounding countries, the neighboring countries, to understand what was happening. And the media is also essential now. especially with, in 2003, we didn't have the same issues that we have with social media. And even though social media is very important to outbreak response and just having information, we also know that it can also be very detrimental because it is a very easy way to spread poor information. So you all from these established institutions are really essential sources of outbreak notification. Okay, so on to our next step. Essentially, you want to know, how do we know that something is an outbreak and it's not just an endemic disease or a normal pattern of disease? So we talked a bit last time about endemic, epidemic, outbreak, and all those definitions. And so, we talked about how malaria is an endemic disease in many countries across Africa, in fact, in the entire African region. And so how will we be able to know that there's a malaria outbreak or epidemic versus just the normal malaria that happens all the time? And so we do that in two ways. We first establish a baseline of transmission, and then we compare that with the current problem that we think that we're observing. So here's an example. So just to kind of back up, epidemic diseases are what I've been calling epidemic prone diseases. They're basically diseases that can produce a larger than expected cases in a short amount of time within a geographic area. So they don't always do that, but they can. Not all diseases can do that. So one example is influenza. So we know that there's seasonal influenza. So we've heard of seasonal flu. That's expected. You can't say that every winter we have a flu epidemic. No, we usually just have a baseline of flu cases. However, there are some winters where we do have an unusually large number of seasonal flu cases, and this would be called an outbreak of flu. So you can see in this example here that we have, if you look between 2 and 3, that dotted line is the national baseline of flu cases. And then we can see that in 2006, it was pretty much along the national baseline. It peaked in February and March, and the same thing happened in 2008 and 2009. It kind of followed that pattern. But in 2007 and 2008, it was much higher. So this does not follow the normal pattern observed in flu. So this is an example of an outbreak of influenza. Okay. So the next step is to define a case and then count them. So we're going to spend a bit of time on this because I think it's really important. What we need to do in order to really follow and track an outbreak and do what we can to stop it is to classify the cases consistently. You can't have one person saying that a case of COVID-19 is someone who only sneezes and only has a temperature, and then someone else saying the case of COVID-19 is someone with no temperature but with a dry cough. Then it would be impossible to really capture all of the potential cases of COVID-19. So it's important, this is why we use the case definition, which is a set of uniform criteria used to define a disease for public health surveillance. This usually includes some type of clinical criteria, so something to do with actual signs and symptoms how you're presenting clinically, as well as laboratory criteria. So when we think of confirmed cases, it's usually those who have been tested and have a positive laboratory diagnosis, but it also can include and it should include an epidemiologic linkage. So going back to that person, place, and time, those variables need to be included as well. And cases are usually classified at several different levels. So you'll have like a suspected case, so that's someone who is believed to have the infection because they meet all the clinical signs, but they don't have necessarily the laboratory, they don't have the laboratory diagnosis. That could also be a presumptive case, but sometimes people die before we actually know what's happening. Sometimes they die before they can get tested. And so based on, talking to different people around them or understanding who they've been in contact with, maybe they're a contact of a confirmed case, then we would call them a probable case. There's also interim case definitions that change as we know more information. In fact, case definitions usually change for novel diseases as we know more information. And there's also usually case definitions about primary and secondary cases and contacts as well. So some things to remember about case definitions is that they can be tailored locally. So WHO does usually develop case definition criteria that can be used, and there's usually a core that's very important. But if you think about laboratory diagnosis, not every country has the ability to diagnose every single case. They might have one PCR machine in a country of 8 million people. We had a lot of challenges with the outbreak in Guinea and in West Africa with at the beginning, especially for the diagnosed cases. So that's an example of how a case definition may be tweaked to fit the local realities. But also, like I said, the case definition can also change as we have more information, and we're going to talk a little bit more about that. And then at the bottom, you see sensitive versus specific. And so I'll talk a little bit about this, but I won't go too much in detail. I believe Professor Pai will talk more about sensitivity and specificity as we go into the diagnostic study lecture. But these are important terms, and it's important to know they can be used for surveillance as well. So usually, if you think about sensitive, just think about it can pick up as many cases as possible. So high sensitivity means that you're able to include all potential cases. So you're giving a pretty broad case definition to pick up as many people as possible that could have the case. And so it's really useful at the beginning of an epidemic just to make sure that you're not missing anyone. But obviously, because it's so broad, so say you just say high temperature, then you're going to pick up people who don't have the disease. You'll pick up people who have malaria, who have typhoid, who have all the other, febrile illnesses that you would have a high temperature for. So that's the downside, is that you pick up a lot of people who do not have the cases. And then when you think of specificity, that's more that the case definition is able to identify people who actually have the case. So that's what it's really good for. But because it's so specific, so usually you have numerous criteria, very specific. For a new disease especially, it can be very challenging because you'll miss cases because you don't know all of the symptoms that are associated with the disease yet. So you may remember at the beginning of the whole COVID-19, I remember there were 3 symptoms that we were all talking about. It was fever, it was dry cough, I always forget the last one. There was one more symptom that we all were talking about.
Sore throat.
Yes, sore throat. Thank you very much. And so if you look at the symptoms now, we know that there's a loss of smell associated with COVID-19. There's all those other 3, but then there's muscle aches, there's headaches. I mean, so a very specific case definition in January would have excluded all those other people that we didn't even know were actually exhibiting signs and symptoms of COVID-19. Okay. One moment. So I want to talk a bit more about this, about missing cases and modifying the case definition, because I think it has implications for your journalistic work. So, I'm sorry. Okay. So while modifying the case definition from specific to sensitive is a common occurrence, it can really affect case counts. So you see here that it appears that overnight, the case count, and this is for China, for COVID-19 has increased in one day, basically, by 12-fold. And WHO is saying, don't worry, there's no change in the outbreak, like basically the pace of the outbreak despite the China spike. And this is kind of an illustration of what it looks like if you plot out the cases by day and number. So that one day, it looks like we just have this huge spike. And that is, if I was a journalist and I didn't have like the background and the context, I think that would be a noteworthy story, because we thought the R naught, or the way how fast this this infection is spread, was one thing, but now it looks like it could be something totally different. I put a Lancet Public Health article in the Google Drive that gives you a little bit more information about the study that I'm about to read. So please, when you get a chance on it, you should read it, because it's really interesting. So the China National Health Commission actually changed the case definition for COVID 7 times between January and January 15th and 3rd of March. And they did a modeled study, so just a study looking at the assumptions from the data that they found on the ground. I won't go too into modeling. I think we might have a bit about modeling later, but just know that it's you use software to look at different scenarios based on the data that you have. But they used a modeling study to see if the most sensitive case definition was used from the beginning, how many people would it have captured? And so they said that if they would have used the most sensitive case definition, which I think they were saying was the 5th case definition, and if that had been accompanied by adequate testing, then there would have been 232,000 confirmed cases, as opposed to the 55,000 cases that were confirmed during that same period. So that's huge. There's a lot of people that were potentially missed because of changing case definitions, or because of the first case definition, or the first few case definitions being very specific. So this is also from that article, and it just shows, so at the top here, we have the different versions of the case definition. And then on the left side, we have the different criteria. So epidemiological criteria, clinical criteria, and basically laboratory diagnostic criteria. And you can see that as the outbreak progressed, the case definition became much more, I would say, much more sensitive. So it started to include a lot of things. Before, it was like, if you've traveled to Wuhan, or if you traveled to areas or reported cases around Wuhan, if you have a fever, blood cell counts is over this much, and then it goes to like, okay, if you traveled to Wuhan, to the wet market, you had individuals of people who went to Wuhan. If you have symptoms from areas around Wuhan, it just continues to expand. It continues to get more sensitive. Okay. And it's not just for COVID-19. This is just another example to show case definition challenges in DRC during the most recent Ebola outbreak. So this is a little bit different. It's not just about using one case definition and changing it. It's about 4 countries that all border each other having discordance between their case definitions. So you can see here that for the suspected, probable, community, and case contact case definition, the amounts, the level of concordance is quite low for most of the countries, between the countries for these different time points. For probable, by the time they got to, let's say 7, 8 months within the outbreak, then they had 100% concordance. And then you can look on the right hand for the chart. It's basically showing the number of countries that even had a certain category. So you can see with the probable case classification or case category, only 2 countries had that all the way up to 2019 February. So this is a really early time within the outbreak, and that means it's the most crucial time. During COVID-19, the countries that really were successful at the beginning were the ones who responded very early. So just think of the implications if you are trying to respond to an outbreak that is, you have porous borders, people in DRC can easily go to Uganda and vice versa, and you are classifying what Ebola actually is differently. You can see how it could be quite challenging to contain something like that. Another study that recently came out also showed that the WHO case definition for Ebola is was suboptimal, and it didn't distinguish enough between typhoid and malaria and other diseases that had very similar symptoms at the beginning. And so that means that it was too sensitive. It wasn't specific enough. And since Ebola has been, with us for a while, we've had Ebola since 1970s, but there's a lot of evolution within what we know about the field, or what we know about the disease since the West African Ebola outbreak. The authors criticized WHO and said that they should have had a more specific case definition to guide countries. Okay, so this is, again, taking a step back and thinking about your practice. And so in your countries or in the locale that you work in, are you potentially reporting case definition modifications incorrectly? And this is just a headline from Texas saying that the state officials are excluding probable cases. And as I defined probable cases before, people who died before they got a diagnostic test, but pretty much everything else made it looks like they actually do have the case because they had symptoms before they died, or because someone in their house had the case. And so, not just Texas, I'm sure other places as well can be very strategic in which cases they choose to include or not include in order to make it seem like they're doing a better job than they're actually doing as far as, responding to the outbreak. So this is definitely something to be aware of in your work. So yeah, let's go to the next two steps. All right, so this is really when we get into the descriptive epi, which is the disease detective work that I was talking about earlier. And we're going to go through each one of these steps that really make up descriptive epidemiology. So the core of outbreak investigation is really case investigation or interviewing the cases, because only the cases can tell you what you need to know about their potential exposure, especially in a novel disease or a novel infection. Especially, if with SARS-CoV-2, if you don't talk to the cases, then you have no idea where they could have potentially been exposed. Been exposed at. Like, you may remember that at the beginning of the outbreak in China, we talked a lot about the wet market where we saw the outbreak first occur. So a lot of investigation really happened around what were the animals, or what was available in that wet market that could have been an exposure source. But this happens, case investigation, case interviews really happen in every outbreak investigation. Okay, so we're going to go through a typical outbreak where the cause is not known. And we're using this scenario. And yeah, we're going to use this scenario that I'm going to describe right now. So one day in May, there are 29 people who attend a picnic, and 23 of them become seriously ill. And so what we need to find out is what actually happened. And the first step in doing that is usually to create a line list. A line list is actually usually more detailed than this, and it usually gives the specific person information. So the age, the sex, the location of each person, the date of the onset of their specific illness. So what we're seeing right now is more of a summary of a line list. So just try to remember some of these numbers. Know that there are two different flavors, chocolate and vanilla, different people were exposed to. Here you'll see that very early in the in this outbreak, 3 people died, but then after that, no one else died, but people continued to get sick. And so really, when I talk about disease detectives, just like, if you watch any crime show, the detectives really try to look for a pattern. And it's the same thing with epidemiology. We try to understand, is there a pattern in the numbers that we see? Is there a pattern in the stories that we're being told by the people that are infected or unwell, or people who have died as well? So for this mystery outbreak, we go back to what we learned last week about the attack rate. We first calculate an attack rate. So from the other slide, we saw that if you had chocolate only, there were 18 people who only had chocolate, and all 18 of them got sick. So if you had vanilla only, no one got sick in that group. if you had chocolate at all, so there are some people who had chocolate and vanilla. So if you had just had chocolate within, even if it was in vanilla mix, you also 100% of those folks got sick as well. If you had vanilla, so again, people who had chocolate and vanilla, 5 out of 9 of them got sick, but remember they had chocolate as well. And then if you had chocolate and vanilla, the people who had chocolate and vanilla, 5 out of 5 of those people got sick as well. Okay, so what else do we need to know? So descriptive epi is really good in helping us to generate hypotheses that we can use later with an analytical epi, and we can confirm those later or understand the association between exposure and outcome later. But for something like this, we start by pulling on the knowledge that already exists about the diseases that we already know. So we talk to the cases. So Mrs. Y, the maker of the chocolate ice cream, and her daughter ate the ice cream, and they suffered from nausea, vomiting, and diarrhea. So we think about what other diseases have similar symptoms, what other diseases can be transmitted through food or drinking water, and typhoid comes up. And so, yeah, this tells you just different factors about typhoid that could help us understand if the outbreak that we're seeing, this mystery outbreak, if that's typhoid as well. What it also does is help us to have some estimates, some transmission information to start with. So we know, because typhoid is an established disease, we know what its incubation period is. We also know that typhoid has a vaccine. It's not the most effective vaccine, but it does provide some protection. So when we're talking to more cases, we can ask, have you ever been vaccinated? Have you ever been vaccinated with typhoid? And that might help us to know, why some people, die from this mystery outbreak, or other people just have mild symptoms, or even severe symptoms, but not enough to die. Okay, so going back to the lecture last Thursday, it's important during descriptive epidemiology to build our epi access so that we understand different things about the progression of the outbreak. So we have the time. So at the bottom line, which is the x-axis, we actually know when is the onset of illness. And for 3 of these folks, it's when they actually got sick and died from the exposure. And on the y-axis, we have just the number of cases. So we already know that this is a point source outbreak because, with our case interviews, we found out that they all went to the same picnic. But I just wanted to show that this also just looks like a point source outbreak epi curve, because we have a really quick, it goes up very quickly, and then it stops within 1 incubation period. So that tells us that it's a point source outbreak as well. All right, so how can we use our line list to really kind of test our hypothesis that this is possibly typhoid? So we know that, just if you look in the literature, you know that typhoid usually has an incubation period of 8 to 14 days. So the first person that got sick on May 18th. So what we would do is we would say, okay, well then the event must have happened on May 10th. That's where the exposure first happened. And that we'll use that to say, okay, this is how we'll test our hypotheses. But obviously we have people that are alive that can tell us when the picnic actually happened, and say that they say, no, actually it didn't happen on May 10th, it happened May 13th. Which is just 5 days before the first person got ill. So then we learn through, again, going back to the literature and trying to test our hypotheses, trying to see if what we think it is true. This is before laboratory confirmation, because we could obviously just get a laboratory confirmation, but a lot of times in the field, you don't have that luxury. You're not able to take a sample and send it really quickly, or if you do, it might take some time to get back depending on where you are. So we learned from the literature that actually, depending on the amount of bacteria that you have, you could actually have a much shorter incubation period, or it could have you could have a much longer incubation period. So actually the exposure being on 13th of May still aligns with our hypothesis that this could be typhoid. I also want to show, since that was a point source, we're not really talking about human to human transmission. So I wanted to show you an example of a propagated epidemic. So something that we're experiencing now with COVID, what we experienced with Marburg hemorrhagic virus, as well as what we experienced with Ebola. So something that's really important in the understanding the transmission dynamics of an outbreak is the secondary attack rate. We didn't talk about this last week, so I just wanted to talk really quickly about it. So it's basically the incidence risk of the secondary cases. Or put another way, it's the probability that the infection occurs among susceptible persons of a known infectious person or infected source. And this often, when we talk about secondary attack rate, it often refers to spread within a household or a dwelling unit or really close contacts. And it's really important at transmission dynamic because it actually gives us a lot more information about how one person can infect several people. It also really informs what measures that we put in place to interrupt transmission. So for example, we know for SARS-CoV-2, the virus that causes COVID-19, it's more transmissible in households than the first SARS, as well as the Middle Eastern Respiratory Syndrome coronavirus, so MERS. So isolation and quarantine of close contacts is really recommended when we're talking about SARS-CoV-2 to prevent onward transmission. So I just wanted to, we do these kind of transmission trees in the field to really understand secondary attack rate better. So another part of descriptive epi is really mapping out what is happening in different localities. So this is from a situation report from the Ebola response in Guinea. And it just shows the different prefectures and where there are active cases, where there are no active cases, where there may have been an alert that has come up. So like I was saying earlier, different alerts from either clinicians or communities or whatnot. And that obviously just helps you to allocate your resources, including your human resources, appropriately to respond to the outbreak. Okay, so we're gonna go to the next step now, which is to determine who is at risk. And so in descriptive epi, we often use surveys to collect more information about people who have been infected or cases actually, so that we can understand risks better. Because you may remember just from the reporting that you hear or that you've done on COVID-19, that it doesn't affect everybody the same way, right? We see that there's more severe illness in elderly people, in most countries over 65, in some countries even over 50. We see that children do not seem to be as affected by the virus as older people. So, this type of risk differentiation happens in a lot of diseases. And so that's something that we want to understand as well in descriptive epi. So this is an example of some survey variables that we would, of a survey and the variables that we would use and that we would look at later. So let's just do another example. So this is an example of a summary table of several villages where people have been infected with a disease that we are not quite sure what the causative agent is yet. So you see that this table really just captures the different age groups, and for male and female, how many people in each age group are cases over the entire population. So we're looking for incidence, because we're looking for, and actually here, we're doing an incidence rate because we're looking for per 1,000 as well. So there's different ways to kind of go through the data systematically and understand what's going on. You may have seen at the top left this graph that really shows the proportion of females and males that are being affected, that are cases. I've seen this a lot actually on some country situation reps. We're going to go a little bit deeper into this bottom right chart. So we're actually looking here, the incidence rate per 1,000 over the different years. So it's easier when you visualize it this way. You can really have a different story about what's going on in the outbreak. So here we can see that at 0 years of age, it looks like nobody has a case. And it seems for male and females, the case amount or the case rate is pretty much the same, follows the same pattern until you get to between 20 and 50. So it seems like there are more females who are affected by this unknown disease than males during this age group. But then as we go past 55, then it kind of reverses, and there are slightly more male than females from 55 to 80 that are cases. So what we do next is to really interrogate that data. I'm just going to bring everything up here, and we think about, the different age categories in this example, along with the different gender characteristics that we're seeing. So, when we think about the lack of cases for people that are under 1, so babies, basically, we can think, okay, is there some type of passive immunity? Are they getting some type of protection from their mother's breast milk? Are babies not, if there's an exposure source, like if there's some place that, in the farm that people are being exposed to something, do babies just not go to the farm because they're usually at home? So, we're trying to kind of formulate different hypotheses. Seeing a high risk among older children and adolescents, this actually reflects other disease dynamics. So, we see this in measles, we see this in chicken pox. Is this something that's happening? So seeing such a high divergence of females and males between women of childbearing age, so between 15 and 50, we can ask, is this because they actually have more contact with young children, and young children are the ones that are getting exposed? Obviously not so young that they're less than 1, but still young children get into a lot of things, and mothers are usually the primary caregiver. Are they getting it from their children, or is this something to do with the metabolic demands of pregnancy? So we start kind of thinking maybe there's a nutritional hypothesis behind this. And then seeing that, the dynamic changes over 50, where there are more men who actually are cases. We try to think about, okay, this is a little bit difficult to explain, but maybe it's more sociological. Maybe the older women are staying at home, and the older men, they're kind of out just chilling underneath a tree or something, and that's where the exposure is coming. So these are different ways for us to really determine who's at risk, but also to help us formulate hypotheses to understand deeper what's happening. So that's a lot of steps just to really characterize the data of cases in a novel outbreak, but in any outbreak. And one thing I was thinking about when I was putting together this presentation was, for COVID-19, this has all had to happen at the same time in front of kind of all the cameras, like the constant reporting. And so how do you report on a novel disease where people are affected, but we still have a lot to learn? And one big issue that has come up has been, the conflicting advice on coronavirus safety, with using masks versus not using masks. So this is just, one example of the many different mixed messages we've had on coronavirus. But I think I hope that elucidates that there are so many steps in really trying to understand what's happening on the other side of an outbreak, especially when it's a virus or a disease we've never seen before. Okay, so we have 5 more to go to, but let's go to methods of control and prevention, talk a little bit about analytical epi, which we won't go too deep into since we've been doing that all last week, and we'll continue with Professor Pai, and then talk a bit about environmental and laboratory investigation. All right, so this is just kind of just a decision algorithm that can be used to understand if you are going to go straight into implementing control measures or doing an analytical investigation. in order to understand better what's happening during an outbreak investigation. And usually they both will happen, but this is more about immediacy. So if we are the sort, so if we go, is it an unusual event happening? Yes. Are the source and modes of transmission known? And we say no. And so we do, the steps that I just discussed about the clinical, biological, and epidemiological investigation, and then go through the time, place, and person description so that we can formulate a hypothesis. So could you put your phone on mute? Thank you. So we could formulate a hypothesis. Then we get to the point where if the hypothesis that we have formulated already fits what we are already seeing, we can put in control measures. So if we are hypothesizing from that last example that it really looks like, it's something to do with women of childbearing age and actually has something to do with their exposure to their children, we can fit the control measure to that hypothesis. But if we continue to observe and we continue to look deeper into the outbreak and that is actually not true, then at this point we would want to do an analytical investigation. So do some type of study, like a cohort study or case control, or if we have the resources and RCT. But again, I think this often happens. Often we do the control measures first and then we do a study, but sometimes it happens concurrently. So why do we do methods of control and prevention? To eliminate the threat, to treat the source, really to stop the transmission, to prevent continued exposure, and to protect the population at risk. So I just have some examples of words that you may have heard in response or in relation to COVID-19. So contact tracing and isolation really has to do with like stopping transmission, because we don't necessarily have a treatment for the source, but usually if we had a vaccination campaigns like for Ebola virus, for example, for the Ebola outbreak, will be used to prevent continued exposure. But in COVID-19, we're using social distancing to prevent continued exposure as much as we can, as well as protecting the population at the risk. So you may have heard about shielding the elderly. I know there's kind of contention in that, but still, that's one example of protecting an at-risk population, one measure that we could use. So I brought this back because I didn't really get to go into it last time, but I just wanted to show how measures are put in place to reduce or stop transmission. So this is Norway, and they rapidly rolled out social interventions. So if you look at Norway's deaths today, they have 255 deaths, but it's estimated that an additional 144 to 254 deaths were actually averted because they were able to put up these measures in effectively 3 weeks. So you can see starting March 12th, they banned public events, and there were school closures, isolation of the sick, social distancing, lockdown order. And they estimate that their effective reproduction rate was reduced from 3.8 to 0.6 in 3 weeks. So we know that reproduction rate under 1 effectively stops the transmission and makes sure that the transmission doesn't continue to, or that the cases do not continue to go up. So this is one example of how effective measures can be. So I just want to talk a bit about contact tracing. So along with case investigation, contact tracing is a core disease control strategy for preventing further spread. It's been used for decades. It often relies heavily on the community. I actually found a picture of Ia and myself doing some contact tracing in Guinea, like back in the day. And then you can also see down here, there's WHO talking to different community members. And contact tracing really is, what it sounds like. You find a case, you identify the contacts, but it is quite laborious. It's finding out where people have gone, finding out who they may have, been next to, understanding who has attended a funeral, and making sure you go to everybody who went to that funeral and asking them to either self-isolate or, it's really laborious. And I think the important part of contact tracing is really, the community support, the people that are there from the community that are working with you to really kind of convey your concerns, your messages, and your advice to the community, but also do that back, make sure that the community is able to express how they feel, and for everybody to work together. So it's a really important part of outbreak control and prevention, and doing it as fast. So testing, making sure that you understand who actually has the case, and then finding their contacts, and then either isolating them or monitoring them, or both, is really important to stopping transmission of an infection. Okay, so then we use analytic epi, which we've talked about, but that is what we use to really test and evaluate the hypotheses that we have formulated during descriptive epi techniques. So we start asking questions: is there causality? Is there any association? What is the magnitude of the effect? So all of that stuff that we talked about last week, and we reintroduce the 2x2 tables, and we calculate these different risk ratios. And I just wanted to add that molecular epi is actually a field that is relatively new, but very useful. So I've talked a lot about transmission chains without really explaining what they are, but it's really understanding who is infected who over the different generations of infection. And you can really actually just draw that out. And for years, for decades, we've been doing that manually to understand where the infection started and how it moved through a community. And you can actually do that with genetic or genotyping methods now. And it helps you to trace the chain of transmission much more precisely. And it's used in most outbreaks now. So you may have heard that it is actually found out that even in November, there were cases of, so we found that there were cases of COVID-19 in China before the wet market, so in early November, and they also found that in early January, so before there was any detection of COVID-19 in the US, there were already cases there. They did that through genetic epi, or through molecular epidemiology. Okay, so environmental and laboratory investigation. I guess the main point of this is that laboratory investigation usually happens alongside of epidemiological investigation and case investigation and all of that. It's important to do it as early as possible. That China is often commended that they shared the genetic sequence of SARS-CoV-2 early, but this allowed everyone to kind of build a laboratory protocol and to develop a test so that they could diagnose COVID-19 as well. And so it's really important to set this up as soon as possible, but obviously you don't set this up before you try to control the disease within humans. And wealthy countries are able to do both at the same time. They usually already have, a very strong laboratory network, but it's a bit more challenging in resource-constrained countries. And what that entails is really, understanding what specimen that you need to find whatever pathogen, and then learning how to conserve it. So you've probably heard a lot about the COVID-19 kits, like test kits. So, it's usually a big swab or a long swab that allows you to go to the back of the throat and get virus from there, and then so that it can be analyzed or within the lab. And you also have to find safe and legal ways of, sending these pathogens, because some of these pathogens, if they break along the way, then everybody is exposed. And so that's what that really entails. When we're talking about an environmental investigation, you may have read that there have been some places that people assume that there was no SARS-CoV-2 infection. But if you look at the sewage, you take samples from sewage, they actually found the virus within the sewage sample. So that's actually really helpful to help us understand where there might be silent spread. Environmental investigation analysis have been used a lot, especially with polio outbreaks and the whole elimination strategy for polio. So that's been really helpful there. And at the bottom where it says, when in doubt, take it and save it. So again, as there's an evolving nature of a novel disease, a lot of times you're not actually sure what you should be looking for. And so a lot of specimen is actually saved in really heavy duty freezers, and they're analyzed kind of later within scientific exploration. So now we're finishing, and it's really about how do we continue to monitor the situation, and disease surveillance is just super integral to this, and it should be in place beforehand, like I talked earlier about the IDSR, the Integrated Disease Surveillance and Response Strategy throughout Africa. But obviously for novel disease, you have to add another component to it. And for that component, you have to kind of create a network around it, a communication network, a lab support network, as well as additional training. So when you have that surveillance system in place, then you're able to see, you're able to monitor how effective your measures have been. So after you are able to declare that the outbreak is over when there's no new cases during 2 incubation periods since the onset of last case. So you'll see to the right, we have a headline in DRC that shows that they declared an end to the Ebola outbreak on May 18th because there were 42 days that passed with no cases, and the incubation period for Ebola is 21. So that's 21 days. So that's 2 incubation periods. And obviously this requires, for you to be sure that an outbreak is over, you need to have really good testing, tracing in place. So that is just essential to this. And then communicate findings. The way that we communicate findings is through written reports, meetings with local and national authorities. You may have heard of a SITREP, so a situational report. That's something that's usually produced all throughout the outbreak, usually every day in some really intense outbreaks. And SITREPs really help us to write up the outbreak afterwards. So if we're doing scientific publications or creating guidelines and things like that, SITREPs are really useful for that. But scientists also do a lot of press interviews. You may have seen the WHO representative who almost daily is talking to the press about different things that are happening with COVID-19. So there are multiple ways that we communicate findings, and obviously each one of you are really critical to this. So going back to just thinking about practice. So how can the media prepare the public for necessary control and prevention measures? Again, there are so many ways that you all can use your platform, and that you are using your platform to really help to send the right messages. This is an example, or even to call out topics that are not being explored by the public health officials. So for example, this shows balancing privacy with public health. How well are we doing in South Africa? So really trying to understand what are the limitations, or what limits should there be when it comes to contact tracing or accessing people's private information. And then here's another screenshot of social media disinfo and an online newspaper called The Conversation actually taking time to look at these claims and basically fact check them. So there are several things that the media can do to really support public health during outbreaks. And so finally, this is just a lot of different headlines about how Africa is being portrayed in COVID-19. And, it ranges from, what lessons can be learned. And I'm excited to see that people are recognizing that a lot of African countries have outbreaks all the time, and they deal with large outbreaks of human transmission all the time, or human to human transmission all the time. So there are a lot of lessons that can be learned, but there are a lot of challenges in Africa as well, like not having enough tests, not being able to really trust government officials. That's an issue everywhere. But we're hearing a lot of cases of people possibly hiding cases or hiding numbers as well. Or when it comes to public health measures, there's been both good and bad coverage about maybe the military or the government officials abusing these public health measures and not using them correctly as they should. So there's a lot of different takes, a lot of different angles, and I hope that this lecture will be really helpful to help you to cover outbreaks and epidemics more robustly and more balanced, but also more factually. Okay, and here's some resources, and there's resources in the Google Drive. So if we have questions, yeah, I can take some.
Yeah, we have a question on surveillance system. So the first question is, how effective are surveillance systems, especially from those from the health facilities?
How effective? I'm thinking the person is asking like how accurate they are. And I think it's a
Yeah.
really good question. Yeah, I think it's a good question. And it really just depends. It depends on a lot of things. It depends on the disease. It depends on the country. And the reason why I'm saying it depends on the disease is because some diseases are of international interest. So if we think about polio, there's like literally like a international convergence to eliminate polio. Like we've only eliminated one disease as the human race, now smallpox, and we're getting close to eliminate polio and I think guinea worm. And so polio is highly funded. The surveillance system in most African countries, in India and Pakistan, and places where polio kind of lingers sometimes, it's highly funded by Bill and Melinda Gates Foundation, Rotary International, and so even though that still the data isn't perfect, it's much stronger than some other diseases that don't have as much funding behind it. And then as far as the country goes, one thing that Ian and I we talked about when we did. When I came to Guinea, and he was already in Guinea for the response for the Ebola outbreak, is that some countries, even though the integrated disease surveillance and response strategy has been enforced in Africa since 1998, there are some countries that really didn't implement it. And I think there's a difference between English-speaking countries and French-speaking countries. Even some English countries don't get it right, and their data is weak. But in some French countries, it was really never properly implemented, and so the surveillance they're not really doing surveillance as they should be doing, and so yeah, I think that it depends on the disease in the country, and overall in Africa we do have problems with strong disease surveillance data. Yeah.
Yeah, so actually he was trying to say, if as much as not everyone in the community that goes to the health facilities, how will they capture those missing cases in the community?
Mm-hmm. That's a very good question as well. So there are two types of surveillance. There's passive surveillance and then there's active surveillance. And so passive surveillance is when people come into the clinic and they say, oh, I'm not feeling well. And then you write down their different symptoms. And then that kind of gets sent to the Ministry of Health or the National Public Health Institute. Active surveillance is when you go and look for those diseases. And you can do it in two ways. You can go through the different register, so someone like me or Ia, we would go into a health clinic and we would look at their register. So people had to still come into the health facility, and we would say, oh, you've missed a case, the potential case of measles. This person said they had a fever and they have spots. It looks like it could be measles. Or you could actually go out into the community and look for measles. This sometimes happens by having like a community kind of POC, point of contact, that does the reporting. Like community health workers could do this. They can go door to door and look for specific diseases. But again, it has a lot to do with funding. Unfortunately, it has the diseases that have the most funding are the diseases that are able to pay for community health, or community health workers who get stipends or even fuel to go out and look for cases like that. I mean, if you look at how much you spend on to find one polio case, compared to like how much it costs to find thousands of malaria cases, it's huge. Is a huge difference. So you're right, we pretty much do miss a lot of cases, which is why during outbreak investigation and response, contact tracing is important, because we're trying to find all those cases, because there's an outbreak of public health importance, and we're able to use the resources to find every last case.
Yeah, just one last question. This one is relating to the case definition that keeps changing. The person says, if the case definition keeps changing and the WHO has issues guidelines on what clinicians should use to determine cases, do countries have leeway to pick their own case definition so as to underrepresent the true scope of infection? If so, how can journalists determine this and report about it?
No, that's a good question. So yeah, WHO does give kind of standard case definitions, but they also, within that case definition, they'll say, in addition to like the local reality of the country. So like the example I gave about, not having like adequate laboratory capacity. And so that would allow you to change the case definition, that you wouldn't have to say, laboratory confirmation is necessary for a confirmed case or something, and maybe clinical presentation is enough. So countries do have leeway to change the case definition. If you're saying that a country tries to, alter it in a way so that they show that they're not getting any cases, I think as a journalist, I would suggest just comparing the case definition that is published to the case definition that other countries and WHO are using. And I think it probably would become pretty obvious, but I also think that you would hear an outcry from the medical community as well. So it's important to keep your ears to the ground.
Yeah, that's all for now.
That's all.
Wonderful job, Ngozi. I just want to reiterate the critical importance of understanding not just COVID. Many infectious diseases present as a spectrum. Even non-infectious diseases present as a spectrum. When I say spectrum, let's take coronavirus, right? So you and I could come in contact with the virus. We could even inhale some virus. But if the amount of virus particles are very, very low, we may not even get infected, okay? So there has been absolutely not even an antibody generated in our body. Some of us would then get actually infected, but then we may control it very nicely with zero symptoms. PCR might be negative. At best, we may have some antibodies in our blood after a while, right? Some of us will progress beyond that to actually have cough, actually have fever, not feel well, but still not severe enough to need hospitalization. And some of us will end up in hospital where we might need oxygen support, and the really worse off people will have severe pneumonia, cannot breathe on their own, will need ventilator. And then a proportion, 2 to 3%, will actually die at the end of all this, right? So it is a very, very long spectrum, which is why any rate or proportion that we communicate, and which is why I sent that email yesterday to talk to you about the importance of the numerator, clearly defining the numerator, clearly defining the denominator, because depending on how you define these two, the implication completely changes, right? I can show whatever I want to show based on how creative I am about how I define the numerator and how I creatively define the denominator, which is why politicians latch on to things which make them look good. They will deliberately portray those numbers that make them look good. In India, all the Indian politicians are talking about right now is what they call a recovery rate, okay? Recovery rate is what they've latched onto, and they're not talking about other numbers. To me, that's a red flag that people are simply not understanding how to understand these reporting numbers and how you need to report more than one type of a number before you really start understanding it. So infection fatality rate is very different from case fatality rate, right? That's a nice example of the difference between the two. COVID deaths are not at all easy. I mean, you saw that piece, wonderful reporting from India on how challenging it is for India to get the COVID death numbers right. Lots of people have died with no COVID test done on them. They haven't even managed to get into a hospital because the hospitals are overcrowded, and they've been silently buried or cremated, and they're not even counted. They're not even counted in the numerator. They're not counted in the denominator. There's massive underreporting of deaths, even in countries like Brazil, even in the United States, there's underreporting of COVID deaths. So if a politician says, oh, we have very few COVID deaths, you really need to query that and say, what exactly do you mean? And try and cross-reference this against other sources of data, right? For example, in India, journalists have gone to crematoriums to see how many bodies have been deposited there for cremation. And they say that's completely out of sync with what the local government is reporting in terms of deaths, right? So you need to come up with all sorts of interesting ways to triangulate this, and it is far from straightforward. So that's why every numerator and denominator needs to be carefully defined, and you should say how much underreporting or bias is there in the numerator and the denominator. And we're not even talking about sensitivity, specificity of every test we are doing. That's a whole another additional layer of error. Not everybody with COVID will be positive on PCR. And not everyone with antibodies actually has COVID. So that's why we need to understand that every test, no matter how good the manufacturer says it is, has its own inbuilt error. And if you collect the sample too late, the test will be negative. You collect the sample too early, the test will be negative, right? So there's all sorts of interesting errors that makes this so complicated. So it's wonderful that we have Ngozi and Iya who actually done outbreak work in the field to give you a sense of how challenging this is and how we should always look at every data skeptically and query what has really gone into how the data got collected. Any other questions? We do have time. You can unmute yourself and ask.
Thank you. We have a question here.
Yes.
It says, regarding determining who is at risk, it seems that there are a number of inferences that are made or hypotheses. What is the importance of testing each one instead of what we have been seeing, that X symptom is due to Y? And how do we as journalists ensure rigorous testing of hypotheses is done? So it's about testing hypotheses. He's saying that instead of testing hypotheses, why don't we proceed with the existing ones? I think there is a misunderstanding about an unknown disease that we don't have much evidence on, and an existing disease that we already know about.
Yeah, thank you. Yeah, I'm sorry. There should have been a distinction in the presentation. So, for example, the first example, when the people were getting sick from having chocolate and vanilla ice cream, the hypothesis, we actually used existing. We knew the first thing that epidemiologists do is they think about what exists, right? We don't just go straight into something that we've never seen before. So even with, SARS-CoV-2 or COVID-19, the reason why we knew it was something that we had never seen before is because of the genetic sequencing that had been done. And we saw that it actually didn't align with any other virus. It was closely related to SARS, but it didn't align exactly. So we knew it was a new virus within the human population. But for other things, like especially when it comes to like foodborne illness or people, going somewhere and everybody getting sick, we have, we have books and a lot of literature to go to think about what, as well as experience, and there's also clinicians who work as epidemiologists who have this knowledge as well. We have places that we go to first. So in that typhoid example, I was showing that, we saw something that we weren't quite sure of, and we didn't have diagnostic capacity at that point, but our hypothesis went to what we already thought. So maybe the list was, this could be listeriosis, this could be typhoid, this could be this. And after we did a few case investigations and spoke more to the people who actually got sick, we thought, okay, actually this sounds like typhoid. So that's the way you would normally go, is going for what you know already first. When it comes to a disease where we don't know the causative agent at all, and it doesn't match with anything else that we have, or it's a novel disease or a novel infection like SARS-CoV-2, then there are several hypotheses that you can test, but that is built on the information that you're gathering. Again, you're still not shooting in the dark. You're gathering information, and as you gather information, you're publishing articles, you're trying to build up, kind of scientific repertoire so that we can make associations, we can understand what's actually happening. You're doing analytic epi as well to see if there are any strong associations or whatnot. But I think one of the challenges, I would say, for SARS or for COVID-19 is that usually that happens over years. That happens over years, and we do meta-analyses, and we have strong evidence so that we can say, you know what, yes, smoking causes lung cancer. We can say that with certainty. Over years of scientific research and publishing and things like that, and we could say different things about malaria, and we can say different things about TB. Again, even in those fields, we don't know everything, but we know a lot. But for COVID-19, a lot of the stuff that usually happens in the background or happens in academia or happens at WHO, it's being displayed in front of everybody. So what it looks like is that, we're changing, we don't know what we're doing, or we're changing advice all the time. But the truth is that information just keeps coming as we learn more about this disease. So that's actually what's happening. Madhu, do you want to add to that?
No, I fully agree. And people think that things changing is a bad sign. In a new disease, things changing is the only constant, right? There's so much we didn't know about this virus. There's so many things we still don't know about this virus. So in some ways, and I heard this from somebody else, that the media is not very good at communicating uncertainty. People seem to want hard yes or no answers, black or white. Everything is crystal clear. And when the minute it starts becoming uncertain, media is not happy, politicians are not happy, public is not happy, and they hold WHO or public health leaders responsible for uncertainty. When in reality, anyone who looks too sure about what they're doing in this pandemic, we should look at them with suspicion. Really, because nobody in this pandemic has the answers. Everybody is falling, failing, recovering, climbing back onto the saddle and struggling as they go along. So I'm simply not convinced that we have the answers. I did a whole webinar this morning on exemplars in global health with Bill Gates and many others, where the entire discussion was on how some countries are doing better than others, and what we can learn by comparing the high performers with the not so good performers. But even the high performers suddenly discover that cases have come back, right? So nobody is able to even say, oh, we brought the cases close to zero and then hang back, and then boom, the virus comes back, right? And that's a whole another story of how every country is now seeing a resurgence in cases. Some countries are not even done with the first wave, and others are already dealing with the second wave. And this is going to continue for a long time. As Dr. Soumya Swaminathan said today, this is a marathon, not a sprint. So we got to be in this for a long time and stick with it. And we'll have to do all the grunt work. And I think the media can play a very critical role here in informing the public, even informing policymakers, to be honest, because they're not able to keep up with the latest. Any other questions, comments?
I think you've answered all the questions so far.
All right, we will anyway do the Q&A document based on all the questions that you put in the chat. And I will post the video of this lecture in a couple of hours, so you'll have it on the Google Drive. Some of you said you are struggling to open the video. Sometimes I also click on it and it doesn't open. I think you need to have sufficient bandwidth and click on it. It should still work. If not, please contact Ia and Chido and we'll figure out another way to make sure you have access to the videos. Is that okay? All right, so I will send the link for the Thursday lecture the night before, and it will be on bias and confounding in epidemiological research. So until then, we wish you well. Please continue to look at the videos because these are all lots of new concepts being thrown at you. So repetition or revision is really helpful in helping you keep up with the material. Thanks so much. Thanks, Ngozi. Ia. Bye, everyone.
Thank you.
Thank you, Madhu. Okay, bye, everybody.
See you soon.
Thank you.
Nice evening.